I make no excuse for starting with the question, what is allergy? Let's get down to business. And you might not realize that this is a part of our immune system that we used to need years ago when we were all likely to be troubled by parasites. So we don't need this part of our immune system now. It's kind of redundant, and that's the area of the immune system which is misbehaving when people suffer from allergic reactions. So in a parasite attack, the immune reaction is useful because the symptoms contribute to the elimination of parasites. Whereas in an allergy attack, the immune reaction is not only useless, it can be dangerous. I'm indebted to Professor Martin Church, immunochemist, for this next little series. But I want to introduce you to the cast list. First of all, we've got the allergens, which are here. And then this is a surface layer, an internal surface, so it's a mucous membrane. It might be the gut, it might be the lung. It matters little. And then these, the symbol Y, these represent molecules of immunoglobulin E, or IgE, and these are important cells of the immune system, and they contain histamine. And then we've got nerves, and we've got blood vessels, and mucus-secreting cells in the mucous membrane. So these are the players. Now, a little next sequence explains what happens when an allergen actually crosses the mucosal surface. So here we go. The first thing is that the IgE molecules are attracted to the mast cell, and then the allergen hits a pair of IgE molecules and causes release of mucus across the surface. So think of the mast cells as grenades. Oh dear, it's not working. What do I do next? So the nervous system is the next one, and people with allergies know all about this one: itching, sneezing, etc. Intestinal movements, coughing, general nervous system activity. And then the effect on the blood vessels, you know, the first thing is that the tissues become red as the capillaries dilate. And also they can be made leaky and release fluid. So this is tissue swelling, which can affect the skin, the nose, chest, throat, abdominal pain, etc. So if we add all those together, this is where we use the term anaphylaxis. So there's the mucus production, nerve stimulation, and the capillary dilatation and leakage, and those are what cause the various effects. But we regard anaphylaxis as requiring either wheezing, throat narrowing, or drop in blood pressure. Otherwise, we're talking about a less severe allergic reaction. So that's what it is. And I thought what I would do today is give you some case histories, really because each of these case histories taught me something. And so I hope that will apply to you as well. And my guess is that as many questions as I answer, I will raise other questions. But that's actually what medicine's like. Everything you solve, there's another question waiting. First of all, let's just review Anaphylaxis Death. This is the work of Richard Pumphrey, an important piece of work. Back in the 1990s now, But you see, it's actually quite easy to think in terms of 50% of it's caused by doctors or other drugs. A quarter is foods and a quarter is venoms, bee and wasp. But when we look at anaphylaxis incidents, the pattern's rather different, and a lot more comes from food. So there on the left-hand side, you can see peanut, walnut, other nuts, seafood, milk, and other foods. And then the venoms, drugs, latex is there. And this was in a series of 172 consecutive UK anaphylaxis incidents that Richard investigated where he was based in Manchester. But I want to draw your attention to the unknown. That's actually 20% of the total. And the figure actually has not changed very much. So still about 1 in 5 of the people that we see, we struggle to explain why they've suffered the reaction or reactions. So this is the first case, meal out at a pub, chicken chips and onion rings. And she thought it was the onion rings because they made her mouth itch, and she found that her throat was swelling, she couldn't breathe, and she was actually blue lighted to hospital. And luckily she made a recovery, but it was quite a severe attack. Now, the important thing is she had a history of asthma, which makes her at increased risk, and she had suffered anaphylaxis due to a peanut bar in the past and been diagnosed with peanut allergy. And there was an awareness that traces of peanut had caused problems since. So she was advised that the reason for this attack had been traces of peanut in the meal. But one thing I am very grateful for quite frequently is patients who actually go into it themselves. And she actually knew the chef in the pub. And so she obviously tackled him and said, you know, what are you doing? And he said, not me. This is very unlikely that there was peanut contamination, and he explained why. So the onion rings came under focus, and she did her own research and found that the onions were grown in Lancashire, they were made into onion rings in Cheshire, and the batter mix was imported from Holland. Now, this was 2005, and at that stage, lupin was not on the list of foods which require special labeling. That came in a bit later. And this actually was the first case that was described in the UK. We were aware of it from literature from Europe, but this was certainly the first case that I had seen. It actually was listed as an ingredient, not listed on the onion ring pack, although it was listed as an ingredient of the batter mix. So we have lots of skin prick tests in the clinic, and it's a fairly simple technique, but we did not at that stage have lupin as one of our tests. We did again until recently, although unfortunately the laboratory that produced that extract has now gone out of business, so we're back to struggling again. And when we struggle, what do? We take some lupin flour, we take a small bottle and a pipette, and we make a dilution, typically about 1 in 100, and we skin test using that. And the skin test procedure is actually very straightforward, although I don't recommend that anybody tries it at home. But it's as simple as this. So a drop is placed of each item on the skin, and then with a tiny, shallow lancet, the very surface layer of the skin is pricked, not enough to draw blood, and it's just breaking the waterproofing layer on the surface. And then you get a nice little readout. And we do a negative control. I haven't shown it here, but we also do a positive control using 1% histamine. Now you can see that I've actually there tested lupin flour, the peanut, and also pea. So we're thinking legumes, okay? The other way of testing involves looking for the antibodies in the blood. And again, the little Y symbols, and this shows you why we use a Y symbol to represent them. It's the shape of the molecule. So in the laboratory, the test allergen is coupled to a tiny cellulose disc. And then the patient's serum is added, which contains IgE specific to a multitude of things, potentially. And the specific IgE binds to the test allergens. And then fluorescent labeled anti-IgE is added. And that binds then to the specific IgE. And then the fluorescence is measured, and that gives a readout of the result of the test that used to be called RAST, radio-allergosorbent test, but it's actually a fluorescent test now, not a radio-labeled test. It's the same idea. And this was the results of this patient. So strongly positive to lupin and peanut, with a lower grade reaction to green pea that actually caused her no symptoms at all. So the first dilemma that we've got is that these tests we've got, the skin prick test or the IgE blood test, they're actually not allergy tests, you might be surprised to hear. They're looking for immune system sensitization. So if you like, that's the precursor to allergy. But it's very important to understand that random allergy tests, screening for allergy by people who don't know what they're doing, are unwise, because you'll come up with false positives. So this was a study showing cross-reactivity between peanut and lupin, we've now become aware of, stronger in those with a history of pea allergy. So we're not talking about a nut cross-reactivity. Peanut is a legume. And here's a typical patient progressively developing allergies to pea, lentil, haricot bean, and finally lupin seed. And just to give you an idea, this was a French study that of people who are allergic to peanut were tested with a skin test to lupin, and 11 of them were positive, but when challenged, 7 out of those were actually positive. The study in the UK suggests that we may not have quite the same level of problems with lupin amongst those with peanut allergy, but it does exist and it is there. And you're familiar with the list of the 14 foods. Legumes, there's only soy, peanut, and lupin represented there, but other legumes, such as chickpea, such as green pea, such as kidney bean, are actually not there. So this is a theme I'm going to touch on later, because it's easy to assume that the 14 on the EU list are the allergens and everything else doesn't count. But as a clinician, I can tell you that is not true. It's simply, we've got a list of the ones that we encounter most often. The next patient had a meal out at Wagamama. And she was thinking the omeprazole that she was taking for heartburn and reflux symptoms was the reason for the problem, but I said, no, I don't think so. I think it was something in the meal that you had. Now, it can be tricky when you've got the patient in the clinic. What did you eat? Well, I ate some noodles. Yeah, but what was in the noodle dish? Now, I think Wagamama had done a good job here, because I went on their website and it was excellent, because it showed me exactly what. What she could remember was that there was pickled ginger in the meal. Now, I didn't think that was the reason, not come across allergy to ginger. But it helped, because there were only 2 foods which actually contained pickled ginger. And I looked at the list of possibilities. She couldn't tell me which was the meal, but there was curry spices, prawns, bean sprouts, sesame seeds, shrimps. And I thought, well, let's start off with skin prick testing. So we did some skin prick tests. Nothing came up. So let's look again. Then there were some words I didn't recognize. You know, I thought, what's udon? What's chikua? What's soba? So time was ticking on in the clinic, but we looked these words up. And I discovered that chikua is surimi. And I thought, what's surimi? Now, surimi, I thought, well, now we're getting somewhere. It's a paste made from fish, right? Now, chikua is actually these little circles here. That's chikua. So I thought, well, I'm learning something. But what's udon? I discovered udon means wheat. It's wheat flour, yeah? What's soba? Soba is buckwheat. So we did some more tests, and buckwheat came up strongly positive on the skin test, and we did a specific IgE blood test, and that was also strongly positive. So she'd actually developed an allergy to buckwheat out of the blue as an adult. Relatively unusual, and at that point in time, I always ask myself, why has this happened? Because food allergies generally develop in infancy, and people grow up with them. And food allergies that arise de novo in an adult, you've got to think, why? Now, there's a number of case reports from all over the world, but I happen to know that in Japan and Korea, this allergy is actually quite common. You might ask yourself, well, why should that be? Why should they have a big problem with buckwheat and we don't? And I think this case here, which is the one which gave rise to fatality, gives us a clue, because they've done work in Japan, and they believe that the reason for their high level of allergy is the fact that they use buckwheat husk as a stuffing for pillows. So people can become sensitized to the dust from the buckwheat hulls through breathing them, and they can develop asthma because they're sleeping on buckwheat pillows, and then they develop the food allergy. Now, I asked the patient, you know, what about special pillows? Because they're actually regarded as kind of health-giving, and they're supposed to give you wonderful dreams and that sort of thing. Well, I asked, but no, she'd not had any exposure to a buckwheat pillow. Now, it was my thanks to the Anaphylaxis campaign, because it was at this point in time, because I give advice to the campaign, that they asked me to comment on a patient who'd gone on the Anaphylaxis campaign from the USA, who couldn't find any information about buckwheat allergy in the USA. And so I actually exchanged a few emails with this young woman. And this was her. She'd suffered anaphylaxis after a bagel, blinis, gluten-free bread, which can commonly contain buckwheat, but with negative allergy tests to gluten, etc. In the next attack, the thing she remembered was eating buckwheat noodles at a restaurant, awoke to find herself in hospital on life support. And then she herself realized the buckwheat connection and got herself tested, and it was positive. But again, I went in first of all with my buckwheat pillow question. And she said no, but when she was 17, she remembered that a cuddly bear, which actually you could stick in the microwave, so it was warm and smelly because it had lavender in, and it gave her severe nose and eye allergy, and she was told, oh, it must be moldy, you're allergic to molds. But hang on a minute, the bear is filled with scented lavender and buckwheat. Heat him in a microwave oven and he will radiate long-lasting therapeutic warmth that is both comfortable and healthy. But be careful, one day he could kill you. So back to Melissa, but no buckwheat pillows. But then I remembered something else I'd read, and it concerns, believe it or not, the omeprazole, which is a very powerful antacid. And people use it, and it's a very, very powerful drug for people with reflux problems and heartburn and the like. So I looked up the papers. Now, this is what happens to the intragastric pH with a single oral administration of omeprazole standard dose to 10 adult volunteers. So it takes the pH from around about 2 to around about 4. So under the influence of pH 2 or pH 5 respectively, what happens to the food proteins? We're talking about digestion, you know, breaking down of the protein into peptides which wouldn't have any capacity to sensitize. And clearly at pH 2 it's doing a good job, and at pH 5 it's, you know, causing poor breakdown of those proteins. And this is another way of looking at it, and this is actually using simulated gastric fluid at pHs 2 and pH 5. This is in the laboratory to see what happens to ovalbumin. And on the left-hand side, you can see full digestion pretty much by an hour, certainly by 2 hours. But when pH 5, not much happens. So there we've got a possible reason why somebody who is on a powerful antacid, exposed to a novel food, buckwheat, a food that normally she might not eat, can become sensitized out of the blue. So back to the list of 14 foods, we've got another one. Buckwheat's not on that list either. Now, buckwheat, I happen to know, is a food that we are now eating more and more of. The consumption is going up quite rapidly in the UK. Think of noodle bars, you know, people on gluten avoidance. So buckwheat noodles are popular, and buckwheat is being introduced to gluten-free products. So my guess is that there is buckwheat allergy out there that we don't know anything about, and we are encountering cases increasingly frequently. Now the next patient is rather different. And her problem started with hazelnuts, with itchy mouth, itchy throat, swelling lips. And she was given adrenaline, and at A&E she was told that your problem is called anaphylaxis and it's due to nut allergy. And you need to carry adrenaline, and she got her GP to do that. She had a history of asthma and hay fever, and was referred to the allergy clinic. But the GP letter also said that over the next few months that she developed problems with banana, apple, soya milk, and she got swollen lips, itchy throat when she tried to blow up a balloon. Now these were all new problems occurring over the course of a few months. So this poor lady was unsurprisingly terrified, because she thought, you know, gradually it's going to increase and increase. Where am I going with this? And when the letter also said she's avoiding all nuts, she's avoiding may contain nuts, she's avoiding all fruits, she's avoiding all soya. And think how many things have got soya on the label. She daren't eat when away from home, and she's terrified, you know, what's going to happen next. So this is an important issue, and quality of life is something we need to think hard about when we're managing, diagnosing, and advising these patients, because it's easy for us just to say, oh yeah, well, you're allergic to hazelnuts, you better avoid all the nuts. Oh yeah, fruit, yeah, well, just avoid it. It's not easy, and it actually wrecks people's lives. But I'm giving this case because it highlights a new area of development that's helping us quite a lot. Even so, it's a new method of diagnosis, but even so, we still start with the skin prick test. But you'll notice that with apple and banana, on the left-hand side there, the tests were negative, although there was a hint on soya. Hazelnut was clearly positive. Over on the right-hand side, rubber latex, the balloon, bottom right-hand corner, is positive. And also birch pollen. Now, when we need to, we can forget about the skin test extract and actually use fresh fruits to test with. And that's what we did here. Fresh apple was strongly positive, and so was fresh banana. And I'm also going to highlight the birch pollen because that comes into the story. So that's what we had, positive skin tests to birch pollen, rubber latex, hazelnut, apple, banana, and soya. And if we go back about 20 years, that's as far as we could have gone, working out, why these allergies were happening and what the significance was would have been close to impossible. But now these various allergy-provoking proteins have been classed into groups. And on the left-hand side, right at the top, the storage problems, these are the major anaphylaxis risk proteins, nuts and seeds and the like. And there's then a group called lipid transfer proteins. Now the next one, PR10 proteins, those are linked to pollen allergy. So we're talking here about cross-reaction. Somebody with hay fever, sensitized especially in the UK to birch, alder and hazel pollens, is allergic to PR10 proteins that are represented in other foods. But there's a low risk, very low risk of anaphylaxis in that particular case, and in the profilins, the bottom group, even less risk. So what we have here is an increasing risk of severe reaction from the profilin proteins to the PR10 proteins, that's the pollen cross-reacting proteins, to the lipid transfer proteins and the storage proteins. So if we look back at our patient and the various allergens we have to consider, that's what we have available now as separate tests. So we can ask the question not, is this person allergic to apple, but are they allergic to apple MALD1? Or are they allergic to apple MALD3? One is a pollen-related protein and the other is a plant lipid transfer protein. Those are the ones we have available as tests. The ones with a dotted outline, we know those particular components exist, but as yet they're not available for testing. So immunocap tests, that means the blood tests that are available. So there's what's possible, and we decided to test the components of latex, hazelnut, and soya. And that actually takes it far enough, because I think you can see that when we're talking about severe allergy, which was on the right-hand side, and the storage protein column and the lipid transfer protein column, those columns are negative. PR10 proteins are represented by those, and this condition is known as pollen food syndrome. This condition is known as latex food syndrome. And there's an important bottom line here, because this patient is not at major risk of anaphylaxis. In fact, her risk is very low indeed. So was this anaphylaxis? No, it was not. It was a combination of pollen food syndrome and latex food syndrome. Does she need adrenaline? No, she doesn't. Not recommended. So this actually is a case I present, not because this is uncommon or rare, but this is now the commonest new presentation of true food. This is true food allergy. It's IgE mediated. It's not food intolerance. But we see more of this by quite a way than newly presenting anaphylaxis in adults. People might not realize that, but it is worth mentioning because it's a significant part of the work that I do. So as well as advising people that they need to be equipped with adrenaline, we are also sometimes able to tell them that they don't need to be equipped. And the change in this woman's quality of life, knowing that and having a full explanation, was staggering. Now, I said I giving these case histories because each one has a message. So does the last one. She'd known about her allergy to peanuts, tree nuts, and fish, and she was managing the problem very well due to careful avoidance. But in 2014, she'd accidentally eaten a meal containing nuts, and we decided to see her in the allergy clinic for an update. We did the tests again, confirmed them, and revealed nothing new. But it's almost as if that severe reaction switched on something else, and we sometimes see this. She started to note that her mouth sometimes felt itchy when she was eating foods with seeds in them, and a letter came through for a further appointment. Now, I need not tell you that the waiting list can be long, and she was waiting months to be seen, but that's unfortunately something we have to contend with. But during the intervening period, she suffered from a severe attack of anaphylaxis from which she very nearly didn't recover. She'd been to the dentist that morning to have a tooth filled, and she had a bad taste in her mouth, and she called at the supermarket on her way home. Thought, I'll buy some of those, flatbreads, I don't know. If I've just been to the dentist, the last thing I want is a crunchy biscuit, but she hoped to take away the nasty taste in her mouth. So there they are. Took a couple of bites, and she suffered a severe attack of anaphylaxis. Needed adrenaline from the paramedics, 2 more when she got to hospital, full resuscitation measures, etc. So what's going on? Now, she was obviously thinking of her nut allergy. Could see no nuts. There we are, in bold: wheat, barley. May contain sesame, milk, egg, soya, mustard. But this is a problem that's beginning to concern us, and especially the dietitian. It's almost as if our, I'll call it, obsession with labeling the presence of allergens, absolutely correct, so we should, but it tends to detract the mind from the other items. Pumpkin seed and poppy seed. She knew she wasn't allergic to sesame seed because she'd already been tested. So we did some IgE tests, and up popped poppy seed. Now I'll just point out, poppy seed, 1.5%, and she just had a mouthful, that was all. So it must represent a tiny amount. And up until this point, she'd been aware of itchy mouth. So what's going on here? Now the clue is, and this is a message that I deliver because we tend to think of thresholds and, you know, what's an amount somebody can tolerate, what's an amount that they can't tolerate. What we forget is augmenting cofactors, other things that are happening at the time which might increase their level of sensitivity. She'd had dental surgery, so she had open blood vessels in her mouth, and there was ready access to the bloodstream. We were unable to be absolutely sure that she'd not had a non-steroidal anti-inflammatory such as ibuprofen. We think not, but that also can act as a cofactor. So when we're thinking thresholds, we have to think of what might be making that person more vulnerable on any particular point in time, and that's the difficulty when the Food Standards Agency says it would be very helpful if you could help us to define a safe limit. Unfortunately, it's very difficult, and this underlines that. And it also underlines the fact that labeling can focus people on the items in bold, and they forget that there is potential in the others. So you know where I'm going with this. Pumpkin seed, poppy seeds, sunflower seeds, not on the list of 14 foods. So that's taking things a little bit away, maybe from the subject matter of the day, but it's just to point out that tackling this problem, our work is probably never done. Thank you.
Before I let Michael go, does anyone have a question for him? Fine. Do we have a microphone or?
Thank you. As someone who has oral allergy syndrome, that was like my story. Why do you think there is so much of a proliferation to this pollen food syndrome, particularly relating to birch pollen?
Do you want my theory or what's out there? I don't think there is much out there. But a number of years ago, I was doing guiding fourth-year medical students on projects in Southampton, and we were looking at the potency of grass pollen in terms of triggering skin test reactions, and we had samples of pollens which were from uninfected grass and from virally affected grass. I think it came from the Department of Botany at Oxford University, Cambridge University, I think it was. And we discovered that the virus-infected plants were producing pollen which was far more strongly allergenic than the other. So my theory is that at some point in time, and it's something I must check with somebody who knows the answer to this, and I think we're talking about 20, 25 years ago, because I absolutely go along with that. I've been an allergist a long time, and this problem came out of nowhere, and people said it's because you didn't recognize it before. Rubbish. I've always been a good one at taking a careful history, and it is a new problem. So my theory is that the problem is with the birch trees, and that there was some epidemic that actually altered things.
Okay, thank you. One more question from anyone? Anyone? One final question? Michael, thank you very much indeed.
That's okay.
Thank you.